Hello. Hi. Hello. Hi.
Yep, can hear. Can hear. That's the way,
Tak, memang delete tak apa. It doesn't matter. It don't have to be. Right.
Now,
Okay. Speak camera wants to connect to the for me.
testing 1, 2, 3. Everyone can hear me?
Perfect. Okay. Okay. All right. So let's go back to that. Go back to. So then we can start with.
Hello, good morning, everyone. So today I'm going to do our PEM Academic Day presentation on heat and cold emergencies. So just give me a moment. I will share the screen. Okay, can everyone see the screen? Okay, so today I'm going to present on environmental emergencies, mainly heat and cold emergencies. So this is my content of presentation. We'll talk a bit about heat-related illnesses like heat cramp, heat exhaustion, and heat stroke. And then we will also go to talk a bit about cold emergencies, which are the accidental hypothermia, and a bit about frostbite injury. All right. So first of all, let us just go through why are children at risk of getting all these heat and cold related emergency. So firstly, children produces more heat per kilo of their body weight due to their high metabolic rate. So that's why their heat production is actually much higher compared to adult. And besides that, they also have a higher surface area to mass ratio. So this increase their risk of heat absorption at a hot environment. Other than that, in children, their blood volume is also smaller. So it tends to limit the dissipation of heat through heat transfer. So they will have difficulty in dissipating heat when they are exposed to a hot environment. And besides that, they also have reduced sweat glands, so they have a reduced sweating rate. And in younger children, especially in neonates, infants, they do not know how to express themselves. So when they are dehydrated, they are in need of increased oral intake, we tend to miss that. So their fluid replenishment is different from adult. And also, last but not least, for children, they need a longer time to acclimatize themselves to the new environment. Okay. Okay, so listed here are a few types of children who has increased risk. So for example, children with cystic fibrosis or congenital absence of sweat glands, or those with eating disorder, diabetes insipidus, obese patient, or they have uncontrolled DM type diabetes type 1. And also one of the hot topic nowadays, infants that are being left in automobiles during the hot days under the hot sun, as well as young athletes. So be mindful that when you see such children, then they are more prone to heat-related illnesses. So here, just to share that as we know, in the recent hot weather and all these, there's a lot of heat stroke cases uprising. And lately, in early April, there is a death of a 3-year-old child due to heat stroke. And it is actually the child was being left in a hot car under the hot sun. So up to March, we can see there are 22 cases of heat-related illnesses involving adult as well as teenagers. But recently, on the 14th April, our KKM has came up with the Kenyataan media, and the cases has rise to 45 cases. And out of these, there were 2 deaths, 1 adult and 1 was the 3-year-old child. So this is very sad to see because all these environmental related injuries actually are all preventable. So despite wide public information and campaigns and awareness, there are still children that being left alone in car during every heat wave season. And just for all of us to know, the temperature in a locked vehicle can actually go up as high as 51 to 67 degree within the first 15 minutes. So this sudden rise in the temperature is enough to raise the temperature to a very little level, even to adults. So what more about children, right? So now let us go through some of the definition. So in heat-related illnesses, we categorize it into 3 types, mainly the heat cramp, or some people call it heat stress. Then the second one is heat exhaustion, and the most life-threatening one is the heat stroke. So I'm going to go a bit detail on the definition. So what is heat cramp and heat stress? It is defined as a sudden onset of brief, intermittent, and excruciating cramps at the muscle area, especially for those that has been subjected to severe work stress. And usually in this condition, the core temperature is unaffected. Whereas more related to a hot environment would be heat exhaustion. So in heat exhaustion, there are basically 2 types, but it is not that easy for us to differentiate it clinically, which I'm going to explain in a short while. So there are water depleted type as well as sodium depleted type of heat exhaustion. And for heat exhaustion, the core temperature may or may not be affected. While for heat stroke, as all of us know, it is a life-threatening emergency, and it can cause circulatory failure or CNS dysfunction. And when a patient has heat stroke, their core temperature usually rises more than 40 degrees. So this is a table to share of the different definition in terms of heat cramp, heat exhaustion, as well as heat stroke, and what are some of the characteristics that we can look for when we encounter such illness. So for heat cramp, usually it occurs in a patient or children who are highly conditioned. They already acclimatized to the environment, but they have inadequate salt replacement. So when do these tend to occur? Usually it occurs after severe work stress or basically excessive work. And it's stated here that it is triggered by cold, a bit contradicting. And the characteristic is basically muscle cramp. The patient himself or herself will feel excruciating cramps over the affected muscle. Sometimes they even have abdominal cramps, okay? And if we happen to take some laboratory markers during that time, then the serum sodium might be low with a low urine sodium as well, because they will be salt depleted. As for heat exhaustion, so as I mentioned earlier, there are 2 types. The first type would be mainly water depleted. So in a heat exhaustion state, those that are high risk to get it are those children or patients who work in a very hot environment with inadequate water replacement. And this usually occur during the period of hot weather, like what we are experiencing now in Malaysia, or after physical exertion. Usually, by clinical, if it is due to water depletion state, the core temperature for the patient who is suspected having heat exhaustion usually would be less than 39 degrees. They will have progressive lethargy, they might feel intense thirst, and then they'll be too tired to work or play. They will have some CNS symptoms like headache, vomiting, and CNS dysfunction as well. And if we take some laboratory markers or blood investigation, then we can see that the sodium and chloride will be at the higher side with the raised hematocrit showing hemoconcentration, and urine specific gravity will be raised as well. Whereas for the second type, if we are suspecting it is due to salt depletion, the setting for this type to occur is more or less the same. It is also due to an exposure to hot environment or after a physical exertion. But the characteristic or the clinical feature would be a bit different. So for salt depletion type, the core temperature can raise beyond 39 degrees usually. They will still present with weakness, fatigue. They can have some CNS symptom like headache, and they will also have GI symptom and muscle cramps. And when we do some blood investigation, then because it is named as salt depletion, right? So their sodium level tend to be at the lower side. The hematocrit will still be high, showing hemoconcentration, and their urine sodium would be very low because they are depleting salt. And last but not least, the most life-threatening condition is heat stroke. For heat stroke, it can occur and it tend to occur in extreme age group. So like in our setting, infants, neonates, overdressed infant, or infant who are being enclosed in closed cars, or young athletes like runner. I think last time I had an experience, there was a patient who are car track racer, but the kid is young, is about 10 years old, or any patient with excessive drug usage. And usually heat stroke occurs during the period of heat waves, and they were exposed to excessive exertion. So for typical characteristic of a patient that present with heat stroke, they will definitely have a core temperature of more than 40 degrees. They will have hot and dry skin. They will present to you with circulatory collapse, CNS dysfunction, and organ dysfunction as well, like rhabdomyolysis or renal failure. And for laboratory-wise, the laboratory marker-wise, their sodium and chloride would be at the higher side. And then, of course, the creatinine kinase would be raised, and they will have a low calcium level. So how do we manage? Basically, for heat cramps or heat stress and heat exhaustion, the modality of management is mainly supportive. As for heat stroke, I would describe in a bit more detail in a while. So for heat cramps and heat exhaustion, so usually there is no specific therapy, supportive management, ensure the child has adequate rest, increase the salt intake, and also give them some electrolyte-rich drinks like 100 plus. And if let's say the cramp is severe or prolonged, then the child might be very dehydrated, that they might require IV hydration instead. So the parents have to bring them over to the hospital. As for heat exhaustion, remember to remove the child away from the hot environment. Keep them rested in a cool, well-ventilated place. Then ensure adequate hydration. Usually we'll give oral cold fluids. If you think the child has salt-depleted feature, then we can also even offer tomato juice. And if it is severe enough, treat the child accordingly. If IV hydration is required, then you provide it. And also have a look at the laboratory markers to see any electrolyte imbalances. If there is, then make sure we correct it over 12 to 24 hours. Okay. As for heat stroke, this slide is a bit busy, but do not worry about it. Later on, I'm going to share a more organized flow of how do we deal with a heat stroke patient. So for this slide, I just wanted to highlight that your initial management will still be utmost important. Remove the patient from the hot environment and begin active cooling. Later, I'm going to describe a bit more what are the types of active cooling available. And then do your laboratory markers as necessary. And ensure that you monitor the patient closely with all the parameters listed. And the specific treatment, I will share it later on in a while. Just a point to highlight here. So in the Fleischer and Lewick textbook, they do mention that if in a heat stroke patient requiring inotropic support, their first line of a recommendation will be dobutamine. But having said that, dobutamine causes initial vasodilation. So what their argument is, they think that agents like the alpha agonist characteristic, those with epinephrine or norepinephrine, are not recommended because they will cause peripheral vasoconstriction, and this will interfere with the heat dissipation. So it might compromise the hepatic and renal flow further. However, having that in mind, which inotropic support for us to start, we have to see the clinical condition of the patient at that point of time. Okay. So now I'm going to share a bit about temperature measurement and how do we control the temperature for heat stroke patient. So I think all of us know that for any heat-related illness, it would be the best if we can measure the core temperature, because that will be the most accurate. So we can get the core temperature using the esophageal probe or from the oral cavity, which is less invasive. However, it is a bit less accurate, or from the rectum, we get a rectal temperature probe. If we had no choice, we do not have any core temperature probe measurements, then the axillary temperature can also be done, but just bear in mind that usually it is about 0.5 to 0.8 degrees lower than the rectal temperature. So always minus it out. So in the absence of a rectal thermometer to monitor the core temperature, then you still can proceed with the axilla monitoring. And if the axilla temperature exceeds 40, then you can make a presumptive diagnosis of a heat stroke. Okay? So once you identify that, you apply rapid active cooling measures until the temperature comes down below 39 degrees. So this is based on one of the CPG in India, which I in the right corner. And the recommended cooling rate is actually 1 degree for every 5 minutes. So what I found here from McDermott et al. So they came up with the list of active cooling methods and how effective it is in bringing down the temperature. So what we can see here is a list of active cooling methods, which majority of it, most of us are aware and of how to do it. And this dotted line here represent the minimum ideal rate of cooling. So the optimum rate of cooling in order for us to deal with heat stroke to bring down the temperature is 0.15 degrees Celsius per minute. So the dotted line is here because this is the minimum rate. So this is in between probably is 0.075 degrees Celsius per minute. Okay. But the optimum cooling rate is about 0.15 degrees Celsius per minute. So as we can see, the top few methods, doing an ice water immersion at 1 to 5 degrees Celsius of water can give us a cooling rate of 0.2 degrees Celsius per minute. So that would come up to about 1 degree in 5 minutes. So ice water immersion is very effective. If you do not have ice water, you decide to use temperate water immersion with the temperature about 20 to 25 degrees of water. It is not bad as well. You can reach 0.15 degrees Celsius per minute of cooling rate. And if you use cold water or colder water, the cooling rate is more or less the same. It is slightly lower than 0.15 degrees Celsius per minute. Or if we also have the option to use commercial ice pack, it has more or less the same cooling rate compared to cold water. And if we don't have all these modalities, you want to run the patient through a shower, not hot shower, please. So if you run it at at the normal temperature, about 20 degrees, then the cooling rate is actually below before the dotted line. So it is not so effective because the dotted line is the minimum rate of cooling that we want to achieve. Okay. And for the rest that are listed down here, we can see that the cooling rate keeps reducing. So it is not so effective for it to do it alone. especially evaporative cooling. So usually if we want to apply evaporative cooling, then we better combine it with other methods. Okay. So what are some of the active cooling methods that are very efficient and effective in children when we deal with children that present to us with heat stroke? So you have ice water or cold water immersion. As I showed in the slide earlier, it is effective with a very good rate of cooling. So it can provide effective cooling to especially athletes in the field setting. However, of course, it will cause a bit of discomfort. It can cause shivering, and later on, I'm going to share why shivering is not good in this setting. And it can cause the child to be agitated or combative. And it is a bit hard to do in a hospital setting because we need to immerse the child in a tub of cold water or ice cold water. Okay. Then next, it is the evaporative type of cooling. We can do body cooling with a garden spray or any spray bottle with a fan. So you will spray water all over the body of the child, and then you put a fan in front of the child to let the heat dissipate. Okay. So this is very fast and effective cooling method, and especially for infants and also prepubertal children. It is comfortable, easily available, non-invasive, just that you need to store up the gadgets and maintain the gadgets if it is to be used again. And the third method that is available is using wet sheet with directed fan. So what we can do, example, if the patient is in your red zone, you can cover the patient with wet sheet, or you can use a wet bed sheet and then just put it over the torso and the abdomen of the child, and then spray some water on it and put on a fan to blow it over the wet sheet. So this will help to evaporate the heat loss. So here it is mentioned that the heat loss is comparable to the cooling method using the garden sprayer or the water spraying bottle. And it is very easy to maintain, easily available. And next, of course, I think all of you have seen before as well. You can also use ice packs. Put the ice packs over the large body surface area. You can put it over the torso, the neck, the groin, and the axilla. These are the places where the major arteries are located at. And for ice pack method, it is simple. It is ready available. Shorter cooling time if we combine it with evaporative technique. Okay. And of course, if you need to do a bit more invasive type of active cooling, then you can administer cold IV fluids administration. So once you initiate this non-invasive active cooling method, if you see that the temperature is not coming down accordingly, then you can always initiate cold IV fluids as soon as possible. Okay. And of course, last but not least, this is the most invasive method where we do cold water irrigation via gastric lavage, bladder irrigation, peritoneal lavage, or if in center you do have ECMO, then you can use ECMO. But for this type of cooling methods in children, the invasive type, it is not so well studied, and of course it is invasive. But if you really have no choice that you have to do it, then you will proceed. So these are some of the active cooling methods that I'm going to share. So usually this is the top two pics. The top two picture is showing about ice and cold water immersion. Basically, you need a tub, at least a bathtub lookalike, and with a lot of ice at the side. Okay. So if you have a patient with heat stroke or a child with heat stroke at the field setting, or if your red zone is big enough to put a bathtub, then you can do so as well. So immerse the child in with the head and neck on top. So immerse the body and the legs and the abdomen in. And then prior to that, ensure that you have a core temperature measurement, usually the rectal thermometer, a rectal temperature probe. Ensure that, and also put on some monitoring for the patient, and then immerse the patient into this ice cold water. Okay. And another method, which is more doable in a red zone setting, would be using a body bag. So prepare a body, if we anticipate the patient to come, then prepare a body bag with a lot of ice and wet sheets. So what we can do is fill up the body bag with ice, and you can also put some cold water in to sort of like submerge the patient's body onto it. But for this method, you can only submerge the posterior part of the body. This is more suitable for unstable patient, because for the bathtub method, the patient need to climb in himself, and it's a bit difficult. Okay. This is one of the combined cooling method where we can do, where we combine the ice cooling method along with evaporative cooling. So you can put wet sheets or ice pack over these areas that I mentioned earlier, and then at the same time spray some water all over the body of the patient and on a fan to blow some direct air to the body to evaporate the heat. Okay. And this is to share, we actually have this mist fan for evaporative cooling in HKL site. It is very useful for a field setting actually. So this mist fan is at the bottom of at the base of it, we fill it with water, and then once you on the fan, then you blow out mist. So this, you do not require a spray bottle with a separate fan. So this is like a two-in-one thing. And this is an example of how we can apply ice pack over the major arteries area, the neck, the axilla, and the groin. Okay. And just to talk a bit about some of the invasive method like bladder irrigation, where we can do in our research setting. So if you decided that the child or the patient requiring invasive type of active cooling, then what we can offer is bladder irrigation with cold saline. So for bladder irrigation, if we have a three-way catheter, that would be best. This is a similar three-way catheter as we seen in adult. So in the picture on your left, we can see how do we perform a bladder irrigation with cold saline. So you will insert the bladder catheter as the usual method of how we insert for every child. And then just take a note that there will be 3 ports. So one port will be connected to the cold saline for irrigation. And then one port is for inflation of the balloon. And one port is for the drainage or the water to come out from the bladder. Okay. However, if you do not have a three-way catheter or the size is inappropriate, we still can use our conventional two-way bladder catheter or the Foley's catheter. So choose the size that is required for your patient. If the child is very young, then use a smaller size, and then insert it as per normal how we would insert a Foley's catheter. But for bladder irrigation using our Foley's catheter, we need to do it manually. So you will need to flush in 20 cc or 50 cc of cold saline, and then after you flush in, wait for about 3 to 5 minutes, and then you remove it out. You syringe it out, and then repeat the procedure. Okay. So this is one of the organized, nice management flow that I found, done by Ruby C et al. Okay. So if we have a look here, it is time driven. So initially at the triage, once we have identified that, oh, this patient is having a heat stroke. Okay. So quickly move the patient to the resusc zone, And within the first 5 minutes, our aim is to recognize and initiate the initial treatment. So what are the initial treatment that we need to do? Assess your airway, breathing, and circulation. Make sure we document and check the core temperature. And also at the back of your mind, think about other differential diagnoses. Could the patient be having neuroleptic malignant syndrome or malignant hypothermia or serotonin syndrome or hypothyroidism or sepsis? So for this differential, you need to get more history on it. Okay. And at the same time, because it is teamwork, so place the patient on proper monitoring, establish large bore IV cannulas if you need to resuscitate the patient, then send for some laboratory markers, do an ECG, and probably you can order a chest X-ray for later. Okay. Then within the first 10 minutes when the patient arrived to us, once you recognize it is a heat stroke, we need to initiate rapid cooling. So how do you initiate rapid cooling? You can start with external cooling, which are all the non-invasive method that I shared earlier. And if you notice that within the next 10 minutes, the patient is not improving, then consider internal cooling or invasive method. Okay. And do remember, when the patient starts shivering, it is not good.
Hello? Okay, I think you're up. There we go. And hi everyone, sorry about that. We had a genset problem and now we're back up again. Just give us 2 minutes. Oh, yes, I forgot. Share screen, entire screen. Here we are, share. Am I still up?
Why my face was so much expression?
Okay, I think you're back up. Okay. Yeah. Because
Okay. Can yours?
and it will just reboot.
Can you all hear me? Can. Okay. All right. So sorry for the technical problem earlier because of the genset loading test. So I'm going to continue back from where I've stopped. Okay. So we talk about the first 5 and first 10 minutes of what we need to do if we are dealing with a patient or a child coming in with heat stroke. So by the first 30 minutes when the child is with us, then by this point of time, we should be able to cool down the child to the temperature level of less than 39 degree and avoid re-exposure. So the supportive care should comes in where we will need to monitor the temperature regularly, correct any electrolyte imbalances, and also arrange for ICU admission. All right. Just a moment. Okay. So just a question, something for us to ponder on regarding when we deal with heat stroke patient. Do we give antipyretics for heat stroke patient? Yes or no? Okay. So some of us might be thinking that, well, the patient has fever, right? So give lah. Why we cannot give? However, if it is due to a heat stroke patient, it is proven that antipyretics such as aspirin or even acetaminophen or paracetamol, they are ineffective in patient with heat stroke because the fever and the hypothermia raising the core temperature is through a different physiological pathway. And furthermore, if we do give this heat stroke patient with antipyretics, then it can aggravate coagulopathy as well as liver injury. So I also found that in one of the journals, given in the primary care physician, they explain as well that antipyretics should not be given to reduce the hypothermia in heat stroke patient because the mechanism is due to excessive heat generation rather than hypothalamic induced heat retention. Okay. And it is also written in our clinical guideline, our CPG on management of heat-related illnesses in 2016. So do not administer any paracetamol or aspirin or NSAIDs for heat stroke patient. All right. So this would be the last slide for the heat-related illnesses. So how about admission and discharges? How do we decide on that? So basically, if we are dealing with heat cramps or heat stress patient, they can generally be monitored at ED setting, and then later on they can be discharged once the symptoms are resolved. While for children with heat exhaustion, they might require admission if you find that the child has some signs of dehydration or some electrolyte imbalances that you need to correct. For ongoing fluid and electrolyte replacement and also serial testing. And as for heat stroke, as we know, it is a life-threatening emergency. So children with heat stroke definitely will need admission, and we need to admit the child to the ICU for close monitoring because we worry about other multi-organ involvement. Okay, so the next half of the session, I'll be talking a bit on co-emergencies. So for co-emergencies, I'll first talk a bit on accidental hypothermia. First of all, let us just define what does hypothermia means. So it means that a core temperature of below 35 degrees Celsius, and we can actually divide it into mild, moderate, severe, or profound. So for mild, it ranges from 32 to 35 degrees. For moderate, it is from 28 to 32 degrees Celsius. And for severe, it will be below 25 to 28 degrees. Sometimes some of the articles and some of the books, they did not use profound. Basically, they just use severe. So for severe, you can also categorize it to less than 28 degrees. So why are young children prone for cold-related injuries? So as we know, for infants, for young children, they have a large surface to volume ratio, and they have very small amount of subcutaneous fat. So they conserve heat very poorly, and they are unable to produce heat by shivering. And as we know, children do have brown fats. However, in children metabolism, their oxygen consumption rate is significantly increased. So these can lead to other complications like metabolic acidosis, hypoglycemia, or hypocalcemia. So who are the children that are at a higher risk of getting cold-related injuries? So of course, those young children that are being exposed to cold environment for a prolonged time, or young athletes in cold weather sports, for this type of children, it might not be so applicable in Malaysia, but in overseas, when they have winter sports, then it can always happen. And if for neonate, environmental condition itself doesn't need to be extreme. Even in a normal temperate climate, we can predispose a child to neonate to accidental hypothermia. Just a simple scenario would be sometimes after we examine a neonate or examine an infant, we forgot to wrap back the child. We just keep the child exposed. So that can actually lead to hypothermia, which can be very dangerous. So bear in mind for that. Okay, so I'm going to share a case. This is not a real case. It's just a case scenario. Okay. So we have Elsa, a 2-year-old girl who was found face down at the condominium pool for 20 minutes after the last visual contact. So she was picked up by the security guard without any resuscitation. And the paramedics, the EMS team went over and found her apneic and pulseless. So she was transported to ED with ongoing CPR. And upon arrival, they noted her temperature to be 28 degrees and she remained pulseless. So she received 3 rounds of adrenaline, and eventually we managed to get her back after 30 minutes of retrieval from the pool. So she was intubated and ventilated, and her GCS was 3. Pupils were sluggish but still reactive. And you look at the monitor and the arterial blood gas perform, this is what it shows. So we can, from the cardiac monitor, we can see the heart rate about 114. Then the best saturation that we were able to pick up is about 92% with a respiratory rate of 30 and a blood pressure of 133/94 and the core temperature of 27.3 degrees. And below it is the blood gas. And the first blood gas that you did post-resuscitation, we got a pH of 6.6 and a lactate of 18, a base excess of -21, and a bicarb of 4.4. Okay. And next, because the child already obtained ROSC, right? So you ordered for a 12-lead ECG, and your staff nurse did an ECG. This is the best ECG that she could get. So what can we observe here from the ECG? So we can see there's a lot of shivering artifacts, not a great ECG to be interpreted. But have a look at these red arrows. So what do you think is these points are? So this is these points that that pointed with the red arrow is not normal. Okay, it is not a normal QRS as we seen in a normal ECG. So these are actually the J wave, or you call it the Osborne wave. Okay, so J wave is actually a positive deflection at the J point. So as you can see here, after it looks a bit like the RSR pattern, but it is actually not. Okay, so it is the J wave you can see right at the J point. Okay, that before the J point you can see a positive deflection, and usually it will be more prominent to be found at the precordial leads. And articles have proven that the height of the J wave is roughly proportional to the degree of hypothermia. So the more hypothermic the patient is, the higher the J wave will be. Okay. So now for ELSA, what should we do with such ECG and such blood gas? So should we correct thinking that the ECG, because with the ECG shown, some of us might be thinking that it looks bradycardic, and then the T wave not really able to be seen, and there's some abnormal artifacts. So we will think, some of us might be thinking that the child having some electrolyte imbalances. So should we correct the hypokalemia with fast correction? Or B, should we rewarm the patient? Or C, we do both. We rewarm and we put a maintenance of potassium in the drip. So the answer is actually B, rewarm the patient. Okay. Why is that so? So since we know that Elsa, in Elsa's situation, she was drowned and she was hypothermic, so we always treat the cause, treat the hypothermia fast. So rewarming itself can actually cause rebound hyperkalemia. So if we add on more potassium at this point of time, it will only lead to an additional risk of causing the child to have hyperkalemia. So avoid adding any additional potassium unless the arrhythmia is causing CVS instability, and also check the potassium frequently. Okay. So some of the triage consideration that we need to think about is if we are dealing, if a child or a patient present to us with a history of sudden immersion in ice cold water or prolonged exposure to long cold environment, okay, or trauma patient found unconscious on rainy days, on a wet windy days, okay, as well as infants who are left exposed to cold environment during prolonged medical evaluation. So from clinical assessment, how do we differentiate whether the patient is having mild or moderate or severe hypothermia? Okay, so here I listed some of the features. The features can be, is quite general actually, okay? So most of the time, if a child come into us hypothermic, they will look pale or even cyanosed. And then if it is mild, usually their mentation will be intact. But if it is moderate or severe, for moderate hypothermia, then their mentation can be impaired. They can be drowsy, they can be agitated, or they can be confused. But as for severe, usually they'll be comatose. As for the blood pressure wise, usually mild hypothermia, it won't affect, it won't cause any instability at the blood pressure. However, if it is moderate or severe, usually hypotension will occur. As for the CNS reflexes, the pupils will be normal in mild hypothermia. When it is moderate, then the pupil will be sluggish. and can or cannot be dilated. But if it is severe, usually it will be sluggish and dilated. As for the reflexes, in mild hypothermia, reflexes can be normal or depressed, while for moderate and severe, usually it will be very difficult to get the reflexes in. As for ECG changes, it is not specific, but these are some of the features that we can look for that can guide us, which is how severe the hypothermia is. So in mild hypothermia, ECG can still be normal, or we can see features of just sinus bradycardia, or maybe some T inversions. When it is moderate, then you can see other arrhythmias start to occur. It tends to be atrial fibrillation or atrial flutter, and also presence of J-wave. And of course, it is severe. Usually, it will cause cardiorespiratory collapse. Usually, the patient will be in a ventricular fibrillation state. So these are some of the laboratory markers or investigations that we need to do for when we deal with a hypothermic child. So of course, we need to do a full blood count because in hypothermia, it can cause splenic sequestration. So it tends to cause neutropenia and thrombocytopenia at the moderate and severe hypothermia patient. Then you will always get a renal profile to look at the kidney function as well as some electrolytes and also a serum glucose level because the child can be in hypoglycemic state or even hyperglycemic state. And of course, a coagulation profile because hypothermia tends to lead to coagulopathy. And if it is a severe hypothermia, you might need to consider to take a serum amylase as well because hypothermia itself can cause frank pancreatic necrosis. So the amylase level can be raised. And we also take a blood gas. At the initial stage, the blood gas in a hypothermic patient might show respiratory alkalosis first before it goes to respiratory and metabolic acidosis. So this is the management of hypothermia that I found in the Fleischer and Lewick book. So as per how we manage patient clinically, so you will initiate your initial management, assess the airway, breathing, circulation, and cardiopulmonary resuscitation if necessary, and then do your proper monitoring, our vital signs monitoring, core temperature monitoring. Central venous pressure monitoring might not be feasible for us. And of course, treat the underlying cause, correct the hypothermia early, and correct all these other parameters. Correct the hypoxemia, hypokalemia, hypoglycemia if present, and then temperature control. Okay. So, okay, this one looks like a busy slide, but what I just want to highlight, if you look at the right corner where I highlighted in yellow, so just want to show that there are, in rewarming children with accidental hypothermia, there are a lot of methods. We have the external rewarming or internal rewarming, which I'm going to talk in a while more. And also, if there are centers with ECMO, then of course, ECMO would be the best. So what are the methods of rewarming for hypothermia? So we talk about passive and as well as active rewarming. What is passive rewarming? Passive rewarming is removing the patient from the cold environment and then remove all the wet and cold clothing and use a warm blanket to maximize the effect of the basal heat production. Whereas active rewarming, we can divide it into two types, external or internal. Okay. So some of the external active rewarming methods that we know of would be using electrical blankets, hot water bottles, overhead warmer, or thermal mattresses. These are all easily available and can be easily stored at the center. Whereas people also talk, articles also talk about immersion into warm water bath. Yes, it is possible, but for rewarming purpose, if we immerse a patient into warm water bath, they are very prone to this phenomenon called after drop phenomenon, where a warm water environment, it can cause peripheral vasodilation. So this will lead to a sudden drop in the blood pressure. So it can cause cardiovascular instability in a patient if we immerse the patient into a warm water bath. So be mindful of that. But the other things that we can think of to minimize this after drop phenomenon is using internal rewarming, because internal rewarming is proven to have more rapid and less likely to be associated with this after drop phenomenon. So it is less likely to cause dangerous arrhythmia as well as hypotension. And some of the internal rewarming methods that we can do is forced air rewarming, pleural irrigation, or peritoneal lavage, or gastric lavage, or bladder lavage. And if the child or if the patient requiring hemodialysis, then hemodialysis can be done with the core rewarming method. And of course, if in certain center you do have ECMO, then ECMO can be administered. So now come to a question of how fast should we rewarm the child? So earlier about heat emergencies, we talked about how fast should we cool the child down. So now we will talk about how fast should we rewarm the child. So the optimum rewarming rate is always emphasized, is different from article to article, and it's also different from some localized protocol. But in general, the evidence suggests that the rewarming rate should actually be determined by the patient's circulation and metabolism. So each patient is actually different. Okay, so rapid rewarming is not an issue as long as support is provided for the blood volume and the circulation of the patient. So what I found from Up to Date, they mentioned about, they recommend a mean core rewarming rate of from the rate of about 1 to 2.4 degrees Celsius per hour. As for what is mentioned in APLS 7 edition, they go into a lower rewarming rate, where they allow about 0.25 to about 0.5 degrees Celsius per hour, because they worry about a hemodynamic instability. So this is an algorithm that I want to share. It is obtained from the APLS 7 edition. So here they talk about how to manage a hypothermic child that present with cardiac arrest. So what I wanted to share here is, as all of us know, I mean, we will, if a child presented in cardiac arrest, we will do a cardiopulmonary resuscitation. Then we will see whether the rhythm is shockable or non-shockable. So if let's say it is a shockable rhythm, then continue the CPR and always check the core temperature. And if let's say the temperature is less than 30 degrees Celsius, so remember, if less than 30 degrees Celsius, it has been proven that direct current shock as well as medication won't be that helpful. So what is recommended here is to deliver only 3 times of direct current shock, and with 2 minutes CPR in between, and you will withhold the adrenaline or amiodarone until the temperature rises above 30 degrees. And then only you will resume the shock after when the core temperature goes beyond 30 degrees. Okay. If let's say the core temperature at the point of time of CPR is more than 30, between 30 to 35, then you can deliver the shock accordingly every 2 minutes if required, if it's a shockable rhythm. However, you will double the interval of the adrenaline doses until the temperature is 35 degrees. So usually we will give adrenaline at about a 4 minutes interval, right? So if the patient falls into this category, you will give the adrenaline at the 8 minutes interval, okay? And then listed down here is the types of rewarming methods, the external rewarming as well as the internal or core rewarming methods recommended in dealing with a hypothermic child that present with arrest. So external rewarming, as what I mentioned earlier, the different types. As for the core rewarming, so we can give warm IV fluid with the degree, we set the warm fluid to about 39 degrees. And then if the child is ventilated, then you can actually give warm ventilator gases, put it at about 42 degrees Celsius. And if the child is still unstable, you're requiring invasive method of like gastric or bladder lavage, then you can do a gastric or bladder lavage with warm saline at 42 degrees Celsius. And if worst case scenario, we can also perform a peritoneal dialysis or a pleural or pericardial lavage. I've never seen, but these methods are actually proven successful in children, okay? And in ECMO, if the center has it, okay? So as for the aim temperature, as I mentioned earlier, it's written here in the APLS protocol as well, okay? And then next would be how long should we resuscitate? So as we all know, when we resuscitate a hypothermic, a collapsed hypothermic patient, the duration of resuscitation is usually longer than a normothermic child resuscitation. So the resuscitation effort should be continued until the child's core temperature is 34 to 35 degrees Celsius. So this one I obtained from the UpToDate. This is because the neuroprotective effect of the hypothermia, complete recovery of patients with severe hypothermia and cardiac arrest has been well documented, even after extremely prolonged resuscitation. And in the APLS, they suggested that the resuscitation should be continued until the core temperature is at least 32 degrees and it cannot be raised further despite active measures being taken. Okay. All right. So that is about accidental hypothermia. And this would be the last bit of the cold emergency. This is a second case. So we have Ryan, a 3-year-old boy who was brought to ED as the child complained of pain over her fingers. And the parents noted the fingers seems a bit swollen and discolored. So Ryan's father told that, he saw Ryan was on a stool, climbing up on a freezer and was playing with ice cube in their house about 2 hours ago. So his father quickly took Ryan down, and later on they noticed his fingers to be discolored and swollen. So on examination, the fingertips of both Ryan's hand were firm to touch, looked swollen and appeared red. And the firmness and discoloration extend only to the DIP joint in most of the fingers. And you can see multiple small blisters at the base of his left thumb, as well as the index finger, as what been seen in this picture. So what do you think is happening to Ryan? Okay. So you can see the finger it looks swollen, look glistery, and then looks a bit erythematous, reddish at the tips of most of the fingers, and there are some blisters over the base of the thumb and the index finger. Okay. So you'll be thinking at this point of time, is it related to him playing the ice cube earlier in the freezer? How severe is his cold injury? Does his thumb need debridement since there are blisters? Should I consult a hand surgeon or the burn unit? And how bad is this injury? What is the long-term prognosis for his injury? So you are pondering upon yourself. So what I'm going to talk for the next bit is about frostbite injury. So what is frostbite injury? So frostbite injury is actually injury or destruction to the skin with its underlying structure due to exposure to the temperature or environment below the freezing point of water, which is 0 degrees Celsius. And this damage is caused by tissue freezing, hypoxia, formation of ice crystals in the cells and the vessels, as well as inflammatory response with microvascular thrombus formation. And most common sites for frostbite, we might not experience this in Malaysia that frequently, but in overseas, you will see this more often. Okay, so the common sites of frostbites that usually seen in children would be all the easily exposed area, small exposed area, the cheeks, the ear, the nose, the fingers, and the toes. Okay. So how do we categorize for frostbites? How do we categorize the severity of it? So for frostbite, there are 3 stages. It is more or less similar like how we categorize burn injuries. Okay. So for stage 1, they actually call it the frost nip. So for frost nip, it is very mild. So usually they will present with cold, sore, and painful fingers. The skin can be red and erythematous, or sometimes it will be purplish. But in frost nip, it only affects the initial epidermis layer. As for stage 2, what we call it the superficial frostbite. So it involves a bit deeper to the epidermis layer. And then here, the patient might feel pins and needles. They might feel, initially, they will usually feel pain, and then subsequently numbness will set in. And then you can also see some patches of peeling of skin or some small blisters. Okay. And the last one, or the most severe one, would be stage 3, where they call it the deep frostbite. Usually at this level, it would involve the dermal as well as the surrounding tissue. And by this point of time, the numbness already set in, fingers will be very much swollen. Usually it will look very pale, hard to touch, and sometimes it can turn gangrenous already. Okay. So frostbite injuries can cause a lot of complications. It can lead to amputations. It can eventually lead to some chronic pain, and it can also cause premature fusion of the epiphyseal cartilage that can affect the growth. So in dealing with frostbite injuries, what are the treatment goals? Our aim is to minimize the dermal ischemia, to salvage as much tissue as possible, as well as we want to promote healing to prevent further complications later on. So in the treatment goals in dealing with frostbite injury, we divide it into 3 phases. What we call it the pre-thaw or pre-hospital phase, the rewarming phase, as well as the post-rewarming phase. So in the pre-thaw or the pre-hospital phase, this is what at the pre-hospital care level, or if the patient is at home, this is what we can do. So of course, if the frostbite is due to the patient being exposed to the very cold environment, get the patient out from the cold environment, remove any wet clothing, try to apply some soft padding to protect the affected area, and then always remember, do not rub the affected area, because this, sometimes when we see in movie, they will tend to rub the affected area, right? When they are exposed to cold environment, but this is actually wrong. It can actually worsen the frostbite area. And also remember that do not put the affected area to the direct heat. Example, do not place the hands or the legs to direct fireplace, heat lamp, radiator, or stove, because at this point of time, if the affected area is already numb, the patient would not know when will burn injury occur. We might do more harm instead of trying to rewarm the affected area. Okay. And also do not use any heating blankets or electrical blankets for warming the affected area with a similar reason. And then once we have done the pre-thaw phase, then we go to the rewarming phase. So rewarming phase is actually the most effective therapy to deal with frostbite. Okay. So what we do in rewarming phase is you put immerse the affected area into warm water. The warm water would range about 37 to 39 degrees. If you do not have a thermometer, let's say at home, or let's say in your center, you do not have a thermometer at the point of time to know how warm is the water, you can just use your elbow to test. As long as the water is warm enough for you to dip in your elbow, that would be the ideal temperature for the patient to put it in the fingers. Okay, and put it in over 15 to 30 minutes until the distal area become flush, soft, and pink color. Okay. And always remember, rewarming can be quite painful. So do provide adequate analgesia, be it oral or IV, depending on the condition of the child. And after the rewarming stage is the post-rewarming management. So once we have done rewarming, you have removed the affected finger or the affected area out from the warm water, then always elevate the area and splint the extremity. Put on some loose dressing, and if it involves digit, try to separate the digit separately with cotton. Wrap it with cotton and loose dressing. And then monitor the child closely, get the child admitted. Okay, monitor for any signs of infection, and you also have to monitor whether the rewarming method has been successful or not. And if we are dealing with blisters, as you can see in the pictures, then there will always be a question. Should we debride, or should we aspirate, or should we rupture the blister or not? Okay. So if you are dealing with clear blisters, then you can do aspiration as well as debridement, especially if it involves the joint. However, if you notice that it is a hemorrhagic blister, like in the picture in the far right, then you will try to avoid to debride it, because by exposing it and debriding it, you can cause the risk of infection is higher, and we also want to avoid desiccation. Okay. However, if let's say that hemorrhagic blister is located at the joint area and it interfere with the movement, then you can always do a simple aspiration. And if in this state, then all these children will need to be admitted to a burn unit and be followed up with the wound care specialist. As for tetanus prophylaxis, yes, it is warranted. We should give according to the vaccination age group. And then prophylactic antibiotic use is very controversial. It is not recommended to start prophylactic antibiotic in all frostbite injuries. Okay, and this will be the last few slides of my presentation. So what I found out, some of the updates regarding frostbite injuries. So just early this year in February, the FDA, the US FDA actually approved using IV vasodilator injection to treat frostbite injuries, but this only has been proven to be used in adults to reduce the risk of finger and toe amputation. In children, it has not been tested yet, but hopefully it will come in. So what the FDA did was they did an open label control trial where they randomized 47 adults with severe frostbite and put them into 3 treatment groups. So one group will be given only the IV Ilopros, the vasodilator injection. The other 2 groups, they are being given some off-label frostbite medication. And the second group added on along with the off-label medication, they added on the IV Ilopros, and the third group only being given an off-label medication. So what they found is that they did a bone scan after 7 days of after 7 days of the condition, and then it is used to predict the need for amputation of at least 1 finger or 1 toe. So they found out that in the treatment group 1, where the patients were given only the IV Ilopros, the percentage out of 16 patients, none of the patient requiring amputation. So it was 0%. And then for treatment group 2, where the patient received some off-label medication for the frostbite, as well as in addition, they add on the IV Ilopros. Out of 16 patients, 3 patients, about 19% of the patient requiring amputation. As for the third treatment group where no Ilopros was given, out of this 60%, out of 16 patients, 60% of it requiring amputation. So thus they come up with the approval of using this IV Ilopros to treat severe frostbite. Okay, so after the long presentation, So my take-home message for the presentation today is we have to bear in mind that most of the environmental emergencies are preventable. So public awareness should be emphasized and to be strengthened. And always remember to treat the underlying cause, be it hypothermia or hypothermia. It is very important to treat the cause rather than being deviated into dealing with like the electrolyte imbalances and other injuries. Because this is in order for us to minimize the damage effect and complication. And also remember that prevention of accidental hypothermia in neonates and children are very important because this special age group, they are very prone to hypothermia. I think this is all from me. Is there any question from the floor?
All right, so I don't think there are any questions from the floor. If anyone's got any questions, this is pretty much the entire fellow group only. If you have any questions, you can post inside the PEM Malaysia group and you'll ask Wong. All right.
Sorry, Dr. Yap. Live chat.
The live chat.
Wait, we will read the live chat.
So why? So Dr. Dr. Yap's question was going to be, what is the forced air method of rewarming?
Oh, the forced air method that they mentioned in the articles is by using the warm blanket and then they put in that forced air through the warm blanket.
Oh, I know what you did. Stop. There we go. Okay, and her other question was going to be, how can I warm the fluids for rewarming?
How can I warm the fluids for rewarming?
Yeah, what are your strategies in doing that? Do you put it in boiling hot water?
Oh, okay. So for the IV fluids, right? I'm talking about. So for the IV fluids, we can actually put it in the. In the centers we have warmers, so we can put it in our warmer. Then warm it to the degree of the fluid for IV fluids would be 40 degrees if I'm not mistaken. So we can put it at the warmer at the center. Then once you pre-warm the saline, then you can use it.
Okay. Any other questions?
I posted in YouTube chat. Oh, okay.
Okay. The power's back on. Oh, Dr. Yap said, I thought it's heated air.
If the ETT one is heated air, yes, correct, Dr. Yap. But the force, they use two terms. One is the ventilator heated air, and the other force warm air that they mentioned is about the warm blanket with blowing out the warm air from that tubing.
Can I keep talking?
Any other question from Dr. Yap?
No, I think that's pretty much it. Our normal saline bottle has a recommended temperature of 42 degrees.
Oh, okay. Okay.
Okay, can I
Thank you,
ask
Dr. Yap.
everyone, everyone who's in the audience, can you hear the air conditioning in the background? If you can hear the air conditioning in the background, can you let me know in a while so that I can maybe, do you hear it now more than ever, or is this better? Okay, so just let me know if you heard it buzzing in the background because I need to know whether that's still a problem. Okay, if that's the case, I think we'll call it a day because it's almost 12 p.m. So thank you very much, everyone. Catch you guys soon. We'll end the broadcast now and we'll restart it in a little bit might need some more feedback from the rest of you all in a while. Okay, thank you so much.